for this session. So before we begin, just a few housekeeping notes here. This webinar is being recorded and a link will be shared with all registrants after the session, so you can watch it on your own time. Please use the Q&A feature for all of your questions. We'll have a dedicated Q&A session at the end, so we'll address all questions at the end of the presentations. And if you experience any technical issues, our team is here to assist via the chat. So I'm thrilled to introduce our expert speakers. First, we have Nicole Byrom. So Nicole is a registered dietitian with extensive experience in clinical nutrition and media engagement. She works with Celiac Canada, many of you already know, providing expert guidance on managing celiac disease and gluten-related disorders. As a clinic dietitian, Nicole serves both inpatient and outpatient settings, offering personalized nutrition care to diverse populations. Nicole is also the go-to dietitian for global news, where she provides expert commentary and insights on a range of nutrition topics. She runs a thriving private practice, helping clients achieve their health and wellness goals through evidence-based nutrition strategies. Nicole lives in North Vancouver with her husband and her children, balancing her professional commitments with family life in the beautiful West Coast community. Next, we have Dr. Tala Abu, an academic endocrinologist with a focus on managing thyroid disorders and thyroid cancer. She completed her internal medicine training at the University of Ottawa and a master's in medical education. She then went on to do her endocrinology fellowship at McMaster University, followed by a thyroidology and thyroid cancer fellowship at the University of Toronto. She now has her clinical practice at St. Joseph's Healthcare Hamilton and is a professor of medicine at McMaster University. So let's dive into the presentation. I think, Nicole, you are starting. So
Yes.
I'll let you take over.
Thank you for those introductions, Kaylee. Did we want to do the poll questions?
Yes, let's do the poll questions. Let me see if I can get it here. Launch. Can you see that poll?
Yeah, we can see
So
it.
we want to know, do you have celiac disease? Do you have thyroid disease? Or do you have both celiac disease and thyroid disease? Lots of both so far.
Yeah, lots of both.
We know from our State of Celiac survey, for those who completed, thyroid disease was one of the most common comorbidities that people had alongside celiac disease.
Mm-hmm. And we have just gone over 100 participants tonight, 103, which is excellent. Okay, 100% have answered.
Perfect. So we see that 43% have both celiac disease and thyroid disease. 32% have celiac disease and 24 have thyroid disease.
Okay.
Awesome. Okay,
Very
thank you for doing that. Yeah. We'll end
All
this
right.
poll and get started.
Thanks, everybody, for coming tonight. I'm excited to be, it's funny hearing Kaylee say 8 o'clock, because it's 4 o'clock for me, of course, on the other side of the country. I always love to see where everybody's coming from in the chat, so thanks for sharing that. So without further ado, let's get started in the conversation, and let's talk about celiac disease. For those of you here tonight who have celiac disease, some of this might be a little bit of a refresher, but important for those people who are joining us from the thyroid community to really understand what celiac disease is and the importance of getting screened and tested and following that strict diet. So celiac disease is an autoimmune disease, unlike what often is referred to as an allergy. It is not an allergy. It is an autoimmune disease, and it is a condition where the absorptive surface in our intestinal system will get atrophied or blunted. The villi, which is normally long and healthy, where our nutrients all absorb, when you have celiac disease, that can get blunted down or atrophied down, where there's not enough surface area anymore or absorptive capacity to absorb the nutrients that we need for good daily thriving and functioning in our lifestyle. So gluten, of course, is a protein, and it's found in barley, rye, wheat, and oats, and they're crossbred grains. So we often use the acronym BROW for barley, rye, oats, and wheat. And that's what we have to avoid as a community. So this is just a side profile of what a healthy villi, what healthy villi look like on the left, kind of in that 0 and 1, things start to change, and 2, 3, and 4, you can see how the atrophy really starts, and the kind of that beautiful crypt depth between the two villi starts to shrink, and the villus height starts to come down, and you can see how it would be really challenging for nutrients to absorb. And remember that the villi in our gut is sort of the foundation of our good health. So we really want to maintain that really good, healthy gut system to help with the rest of our thriving and healthy living as well. So because celiac disease is an autoimmune disease, we also know that it is a genetically predisposed autoimmune disease. So people who carry the gene for celiac disease, so there's a couple of genes that we know of, that's our HLA-DQ2 and HLA-DQ8. So both of these genes run in families. I'm a good example of genetics for celiac disease running in families. My mom has celiac disease. My daughter has celiac disease. My husband has celiac disease. My sister-in-law and my niece all have celiac disease. We are all genetically related on my husband and I on them on each side of our families. So it is very apparent in our household and our extended households that this is a definite all in the family disease for sure. So the recommendation is for if you have a genetically related first degree family member, regardless of symptoms, we suggest that you get screened throughout your lifetime to ensure that celiac disease has not turned on. So what we've discovered in a few different studies, there's an ASK study being done in the US right now. Marissa Stahl is doing that one. And what they're doing is they're screening children of school age for both type 1 diabetes and celiac disease. And they are finding a high prevalence of celiac disease among siblings. And what they're finding is the first sibling diagnosed is usually diagnosed, but then when they're screening for the rest of the family, the other siblings, they're finding that they're not really presenting with symptoms as often. So they're saying, well, I feel fine, so I don't need to be screened. But truth be told, we do need to screen regardless of those symptoms. They're also starting to do this universal screening in Italy as well for both type 1 diabetes and celiac disease, and getting some interesting results from those. So stay tuned for results from those studies coming up. So celiac disease does have sort of 3 silos of symptoms, which we call classic or typical symptoms. Then we have our non-classic or atypical symptoms, and then we have neurological complications. So we're going to just briefly touch on each of these. Of course, knowing that celiac disease has over 260 known symptoms, none of which are unique to celiac disease. Because of this, celiac disease has a very low diagnosis rate. Here in Canada, the diagnosis rate is about 85%, although I'm going to present a short slide on a study that actually suggests that that rate might even be higher, but the acceptable rate that we often quote is that 85%. Now, the classic symptoms are those that are diagnosed more often. These are people with that abdominal pain, distension, chronic diarrhea, irritability, weight loss, muscle wasting. Dermatitis herpetiformis can come into this class as well. So these are the people, I often refer to these guys as the tip of the iceberg. They're the ones that are really being diagnosed first, being diagnosed faster, because they're often presenting in that more classic or typical way. Then we have our non-classic symptoms. And I often hear people as a dietitian, people will come in and say, well, I don't have any symptoms of celiac disease. And they may or may not have been diagnosed. I have people who have diagnosed celiac disease and they say, I'm asymptomatic. But truth is, they might be asymptomatic in the classic sense, but not necessarily in the non-classic sense. We can't trick our body into not having symptoms of a disease as serious as celiac disease. So unexplained iron deficiency anemia is prevalent in about 68% of people with newly diagnosed celiac disease. And you can understand why this is, because remember that villi that absorbs all that nutrients, when that is blunted, we no longer can absorb our nutrition. So iron deficiency is one of the most common deficiencies that we see in this community. And people would consider that to be to be asymptomatic, but truth be told, that is a symptom of celiac disease. Then we have things like oral canker sores. In our pediatric population, we see a lot of dental enamel defects. So often we're getting, in the peds especially, the dentist will be saying, well, they're getting a lot of cavities, and parents or caregivers are saying, well, we're brushing our teeth, we're trying not to have, sugary, sticky foods without brushing teeth afterwards. So that might be the first whisper to get tested. Then we have things like recurrent or persistent vomiting, IBS, irritable bowel syndrome, and celiac disease are quite an overlap, not only in symptoms and in diet, but we do need to, whenever we see somebody with IBS, we do want to get them screened for celiac disease to make sure we are treating the right thing. We don't want to treat the wrong thing and not do give the client the best chance of recovery and the best chance of a healthy life. Chronic constipation is, of course, the flip side to chronic diarrhea, but we do see that. We do see high liver enzymes quite often, arthritis, arthralgia, joint pain, osteoporosis, osteopenia. Again, thinking about that, not absorbing your nutrients, not absorbing calcium to help with your bones. That's why we'll see teenagers coming in with frequent bone fractures, and we're wondering why. Short stature in our pediatric population, delayed puberty, and infertility are just a handful of the non-classic symptoms. The neurological complications are something we're gaining a lot more information about, gaining a lot more interest in, and noticing that they are actually increasing in what we would say prevalence now to this disease. So what are some neurological complications? Well, we're seeing a lot of brain fog, dizziness, headaches, migraines, fatigue, depression and anxiety, peripheral neuropathy, unexplained ataxia. If you wanted to learn more about neurological complications, we do have some information on our YouTube channel from Dr. Kroll and Dr. Hogard, both excellent PhD and physician from Sheffield, England at the University of Sheffield. They've got lots of interesting and fascinating information on MRIs of the brain, etc., of somebody suffering with celiac disease. So really interesting and fascinating and helpful, useful information coming out. But these neurological complications we are seeing more and more of. Just on a personal note, my husband actually was diagnosed because of dizziness and brain fog. Those were his two primary symptoms. So they are common. We are seeing them, and they are a good criteria to then test to be diagnosed. So some of these challenges of diagnosis, of course, is because celiac disease has so many symptoms and none of them are unique to the disease, that they're being overlooked and we're labeling things as something else. We're thinking, okay, well, you're iron deficient, we'll give you an iron supplement. Ooh, those iron supplements aren't working, your levels aren't coming up, we'll give you an iron infusion, that will help. But without asking that question, why is your iron not coming up? Why are you having frequent bone fracturing? Why are you having joint pain? So we have to, keep asking that question as to why, in order to really raise the awareness and raise this diagnostic rate. So a 2021 study of almost 17,000 people found no significant difference in the general population versus those with celiac disease for abdominal symptoms. So, abdominal symptoms, gas, bloating, pain, discomfort, these are very common, and we see them all the time as dietitians, and I'm sure physicians are seeing people complaining of GI discomfort on a regular basis. So what this study discovered is that there doesn't appear to be a difference between the two cohorts of people. So what this study found out was that underdiagnosis rate was about 97% in these 17,000 people. Again, as I mentioned, the general accepted value is that celiac disease is 85% undiagnosed. But the big take home from here that I wanted to point out is that recent evidence shows that classic GI symptoms are no longer the primary presentation of celiac disease. So if we're only looking for GI discomfort, then we're doing a disservice to the population, and we're not going to be diagnosing enough people because we're not looking for the right things. We have to really look for those atypical symptoms and the neurological complications. If you are wanting to do a self-check and see if maybe you should be tested for celiac disease, my suggestion, if ever you're thinking, should I be tested for celiac disease? The answer is yes. Absolutely, you should be. But the symptom checklist that we have on our website, which is www.celiac.ca, does walk you through and gives you a really excellent indication of whether or not you should be. So take a look at that on our website, do that symptom checklist, send it to your friends, send it to your family. If you think somebody might have celiac disease, send it their way. And that might just be the trigger that makes them go and get tested. So what does testing look like? Well, it initially starts with just a simple blood test. We get blood tests all the time for iron levels and cholesterol levels and liver enzymes and you name it. So this is just a simple blood test. It's called the IgA TTG, or tissue transglutaminase. I will say that this test is only sensitive for kids 3 and older. For kids under 3, it's not a reliable test. So we want to make sure that if we are using this as a kind of a first step in that diagnosis, that we do make sure that we are using it appropriately. And kids need to be over 3 years old, and you do need to be on a gluten-containing diet in order for the test to come back accurately. From there, if you get a positive screen and you are an adult, you would then go on to get an intestinal biopsy done, which we will be looking for that villus atrophy. If you are a pediatric under the age of 18, depending on the province, we can do a non-biopsy approach to celiac disease. What this looks like is kids will get their TTG taken twice, and if both times it is 10 times the normal level, we can do a diagnosis that way. We do not use that diagnosis for adults at this point in time, but perhaps one day it will be on the books as well. So long-term complications for celiac disease, there are some. I've heard lots of people, again, through my years saying, well, you know, I'm asymptomatic, so I cheat sometimes and I have this or I have that. Having a chronically high TTG level and having chronically high damage done to the intestinal system is a really isn't a healthy choice. So what happens if what happens if I go undiagnosed, and what happens if I don't follow the diet is what this slide really should say. So malnutrition. Of course, if we're not absorbing our nutrients through our gut, we are going to be at risk for malnutrition. Lactose intolerance. So lactase enzymes live at the end of that villi. So lactase is the enzyme that digests lactose. Lactose, of course, is the sugar that is found in all dairy products. So we are finding a high level of lactose intolerance in our community that is undiagnosed and our community that is newly diagnosed. Osteopenia, osteoporosis, again, those bone fractures, the weakened bone, iron deficiency, infertility, nervous system disorders. There are certain cancers that we know are long-term complications of celiac disease. So many serious issues that if we can go on our gluten-free diet and stick to our gluten-free diet, we can be very preventative and help you live your healthiest, best life. How do celiac disease and thyroid disease overlap? Well, we do know that autoimmune diseases like to live together. And as Kaylee alluded to in the beginning, thyroid disease was one of the number one comorbidities along with celiac disease. So those two, and as we could attest to from the poll that we took, those two autoimmune diseases often live together. It is recommended that people who have autoimmune thyroid disease are screened for celiac disease, and also vice versa. So we know that these two live together, and that all patients with thyroid disease should be screened for celiac disease, and people with celiac disease are often frequently being screened for their thyroid as well. I think that is quite common practice. This is just a quick slide to let you see this is why celiac disease and autoimmune thyroid disease live together. We share a lot of genes. And when you share the genes, you share the increased prevalence of the disease state from happening. So I will pass off my talk now to our next wonderful speaker, and I will stop sharing my screen. And Tala, I pass it over to you, and I thank everybody for your time. And Tala, you might need to be made a co-host to share your screen, so just let me know.
Yeah, hi there, everybody. I can't turn on my video. It's telling me that the host has stopped it. So I'll just wait for someone to help with that, and then I'll start sharing my screen as well.
Try now, Tala. I just made you co-host. See if that made any difference. There we go.
Okay. And then let me share my screen. Okay, there we go. Is everyone seeing that?
That looks good.
Perfect. Okay. So, thank you so much, Nicole, for that. And that was a great introduction and transition. Um, Thanks, Kelly, for the introduction earlier. So, I'm Dr. Abu-Hijleh. I'm one of the endocrinologists in Hamilton here. And I'm going to talk about the autoimmune thyroid overlap with celiac and go through a couple things. And also, I loved seeing where everybody was in the chat, so thank you for that. So autoimmune thyroid disease, highly prevalent. So 1 to 5% of the population, that's a huge amount of people. Autoimmune response targets the thyroid more frequently than any other organ in the body. And when we use the term autoimmune thyroid disease, that's a whole spectrum of thyroid autoimmunity. And that means it ranges from subclinical disease to clinical disease. And I'll talk a little bit more about those terms, but subclinical disease is sort of the pre stages of the overt disease. A lot of the time in the subclinical phase, some of the hormones are trending towards being underactive or overactive. In that stage, we follow patients sometimes without treatment, especially if they don't have symptoms. And then over time, they may progress to the overt disease, at which point symptoms become more common, and treatment is usually started in the full-blown or overt clinical disease stage. And the major types of autoimmune thyroid disease, Graves' disease and Hashimoto's thyroiditis. Those are terms that you all might have heard. And when we refer to Graves' disease, we're referring to hyperthyroidism or an overactive thyroid. Hashimoto's thyroiditis refers to a hypothyroidism or an underactive thyroid gland. And in case anyone has ever wondered, the names of these diseases are just based on the names of the doctors who discovered them. And when we talk about these two diseases, they're contrasting ends of the spectrum, so hyper and hypothyroidism, but they have shared immunogenetic mechanisms. And if we break down that process, what it looks like is lymphocytic infiltration, which is certain types of white blood cells from our immune system that infiltrate the thyroid tissue, trigger autoantibody release, which then causes tissue damage and inflammatory reaction, and then eventually altered function of the thyroid gland. So if we look at the autoimmune process from a bigger lens, we can break it down into this process. So we start off with the predisposing factors or the non-modifiable risk factors. These are basically our genetics. And then some epigenetics involved as well. And that's basically the genes that we're born with. And in our scenario, that can refer to some of the HLA subtypes that Nicole referred to. Those are the predisposing factors. And then we have triggering factors. So what is it that for some people triggers the predisposing genetic factors to then become the overt disease? Because not everybody with predisposing genetic factors gets the diseases, and that's a big area of ongoing research. But some triggering factors, and we don't know all of them, are some things mentioned here, at least for autoimmune thyroid disease. So smoking, certain types of infections, iodine intake, although that's less of an endemic issue in Canada, radiation exposures, stress, the fetal micro mechanisms, so during gestation, and then gender. So being female in general almost doubles your risk of autoimmune diseases in general for all autoimmune diseases, and that's true for thyroid disease. So we have the predisposing genetic factors, we have some environmental or triggering factors for those genes, which, as I said, are not fully understood. And at some point, we have the autoantibody production. That's sort of our preclinical stage, and then the progression to overt disease, which is our autoimmune thyroid disease. And the phenotype or clinical presentation of that would be, as we talked about, everything from Graves' disease to Hashimoto's and the in-between diseases. So what are the symptoms of autoimmune thyroid disease? It's a huge spectrum of symptoms. Thyroid hormone does so many important things in our body. But I've outlined some of the main ones here. And because hypo and hyperthyroidism are contrasting ends of the spectrum, essentially the symptoms are the opposite of one another. The interesting thing as we go through this list of symptoms is that there's a lot of overlap with celiac disease in terms of the symptoms, especially non-classic celiac disease presentation. So when we look at hypothyroidism, some of the more common symptoms is low mood, low energy, low heart rate, constipation, so a slower transition in the gut, weight gain, menstrual irregularities for women, some musculoskeletal symptoms, and then skin changes, mainly thickening or dryness of the skin, and then cold intolerance. So feeling cold even when people around you feel warm. On the opposite end for hyperthyroidism, we see a shakiness, tremor, or feeling anxiety, um, fast heart rate, diarrhea, weight loss, again, menstrual irregularities for women, some musculoskeletal symptoms as well. And then in terms of skin, certain types of rashes, and sweating, feeling hot or heat intolerance compared to people around you. A very common one I hear, especially with women, is saying that they'll wake up at night with their bed sheets soaked from sweating, and have to change their pajamas multiple times at night. And Graves' disease especially has a few more specific autoimmune symptoms we might see, and mainly thyroid eye disease or Graves' orbitopathy can be seen in Graves' disease. And that's sort of the classic thyroid stare, or the eyes looking like they're bulging out. So how do we diagnose autoimmune thyroid disease? Really, it comes up in sort of two scenarios. Either it's diagnosed during screening, so incidentally, meaning patients don't have symptoms, but it gets done on the blood work for various reasons, or we check thyroid hormones when someone complains of symptoms that we think are thyroid related. So in the screening scenario where there aren't symptoms, but we find it on blood work, those scenarios are things like when we're screening in the context of other autoimmune diseases. So if someone's been diagnosed with celiac disease and we screen for other overlapping autoimmune disorders like thyroid, and we do the blood work and we say, oh, we think you have an autoimmune thyroid disease. Or patients who have a very prevalent family history get screened. Patients on medications that increase the risk of thyroid dysfunction. So medications like amiodarone, which is a heart medication, or lithium, which is used for bipolar disorder. Pregnancy is another common scenario where we do thyroid blood work even without symptoms. And we might find it that way. And then how do we diagnose it? So it's blood work, and the main hormone that we check in the blood work is TSH, or thyroid stimulating hormone. And TSH is a pituitary hormone. That means the gland in the brain sends this hormone, the TSH, as a signal to the thyroid gland and tells it to make thyroid hormone. And it's a little bit counterintuitive, but a high TSH level actually means an underactive thyroid. A low TSH level means an overactive thyroid. So they kind of go opposite directions. And the reason for that is just because the signal from the brain goes higher if the thyroid is not doing its job. And it's sort of the signal from the brain saying, hey, thyroid, why aren't you making hormone? And that's why it's high. In an underactive thyroid. The opposite for an overactive thyroid, if it's making too much hormone, the signal from the brain is low, the TSH is low, because it's trying to tell the thyroid to shut down the production of thyroid hormone because we already have too much. So it's a feedback loop between the brain and the thyroid gland, where that's what the blood work tells us. We have other hormones, free T4, free T3. We often don't test the free hormones. because they're more often used for Graves' disease and not so much for Hashimoto's, but there are some scenarios where the free hormones can be helpful. And then the antibodies. So the two main antibodies, although there's others, the two main ones are TPO antibody, which is thyroid peroxidase antibody, and that's positive in Hashimoto's. And then we have TRAB antibody, thyroid receptor antibody, or thyroid stimulating immunoglobulin, depending on what province you're in. And that's your Graves' disease antibody. The TRAB hormone is very sensitive and specific for Graves. So if you have a positive TRAB antibody, you have Graves' disease. TPO antibody, on the other hand, is not as sensitive and specific. It can be positive in many conditions that are unrelated to thyroid. It can be positive in Graves' disease and Hashimoto's and a lot of other thyroid conditions. So we do interpret the TPO in the context of the overall presentation. But we do know that most patients with Hashimoto's will have positive TPO antibodies. When it comes to imaging, it's not often done in the classic or straightforward diagnosis of Graves' and Hashimoto's, but sometimes we do an ultrasound of the thyroid, sometimes we do an iodine uptake and scan for the thyroid, especially if we're trying to differentiate it between thyroiditis, which is temporary inflammation of the thyroid, and Graves' or Hashimoto's, or if we felt a nodule on the thyroid, that would be a reason to get an ultrasound. This is just to kind of take a look at the subclinical to clinical spectrum. And I kind of mentioned this previously, where we have the preclinical stage where your TSH might be a little bit high, a little bit low, but your free hormones are normal and you may or may not have symptoms versus the overt clinical disease. The reason that this is interesting or worth noting is because in the subclinical phase, we don't always need to treat patients. And there's different guidelines and some practice variety about physicians at what point we treat. And then the other interesting thing is that we have patients who have positive antibodies. So let's say your TPO antibody level is very high, but your TSH levels are normal or only a little bit high or a little bit low. What over time, how many patients or what percentage of patients will progress to get the full-blown underactive or overactive thyroid? It's about an annual risk of 2.1% per year for every year that we follow patients. Obviously, that can increase or decrease depending on how high the antibody is. So if your TPO antibody is 10, 20, 30, 40 times the upper limit of range, much more likely that that's going to progress to overt disease in a shorter time versus a very mildly positive TPO antibody over time without a lot of other risk factors, with a TSH that's not very high, may or may not progress over time. So how do we treat autoimmune thyroid disease? So for Graves' disease, it's a little bit more nuanced and complicated in terms of the treatment. I should have said earlier that Hashimoto's is by far much more common than Graves' disease. But for Graves or hyperthyroidism, so the treatment's a little bit more complicated. The treatment options are thyroid blocking medications like methimazole, radioactive iodine ablation or treatment, and surgery. There's a lot of pros and cons to the different approaches, and your doctor would go through the options with you. But most commonly, we're seeing patients on methimazole or thyroid medications. Hypothyroidism or Hashimoto's is treated by replacement of your thyroid hormone or levothyroxine supplementation. Synthroid is the brand name in Canada here. So at the stage where Hashimoto's has developed into overt disease, there's certain things that may affect how much levothyroxine you need, so whether that requirement increases or decreases. But in terms of needing it lifelong. Majority of the time, it's a lifelong treatment. There's nothing that's been shown to show cure, meaning once this thyroid disease has developed from preclinical to overt and that tissue damage in the thyroid has occurred, it's irreversible. And we haven't found anything so far that purely cures it back to not needing zero levothyroxine supplementation. The goals of the treatment are both to improve the patient's symptoms and to normalize the TSH level. And we check the TSH level after starting the supplementation. It should not be checked before 6 weeks of starting medication or before making a dose change, because it takes about 6 to 8 weeks for steady state to be reached in the blood. So if we check your thyroid hormone level earlier than 6 weeks from starting the medication or changing the dose of the medication, it may not reflect the full effect of the medication yet. And once we've checked it a couple times and it's in the normal range and we've gotten to a steady state dose, we check it much less frequently. And then, most patients only need to be checked once a year thereafter, once we've reached that level. Just a quick note, I mentioned this earlier, but there's a lot of things that may change the levothyroxine requirement. So for example, pregnancy, your dose will have to go up during pregnancy. Another example is menopause. So after menopause, women often need lower doses because of the decrease in estrogen. So that's a transition time where it should be rechecked a little bit more frequently. Major changes in weight. So a big gain in weight or a big loss in weight will change your levothyroxine requirement, because levothyroxine is weight-based in terms of the dosing. Those are sort of the major scenarios where there's a big change in dose. And then I just wanted to highlight a couple special considerations specifically for hypothyroidism and celiac disease for patients who have both. So absorption is always an important thing in this scenario. So I've picked up celiac disease in patients who've had no symptoms when I've started them on levothyroxine, and I find that I have to keep increasing the dose multiple times, more than I would expect for their weight. And that's sort of a red flag for me to screen for celiac disease, because it may be that they're not absorbing the levothyroxine. And I've picked it up that way. So especially during the period where patients are not yet following a gluten-free diet and that gut inflammation is ongoing and those villi are not absorbing things, levothyroxine is a very finicky medication for absorption to start with. So it can cause increasing requirements. Another thing is patients with celiac, especially again, if there's phases of inflammation and intake of gluten, that can cause a lot of fluctuating TSH levels until we reach steady state. Once patients have been following a gluten-free diet and that gut inflammation is dialing down and absorption is improving, we do sometimes see reduced requirements of levothyroxine. That's not always the case, and because there's a lot of other things that play a role here, but we would be checking the TSH levels maybe a little bit more frequently when someone is diagnosed with celiac, and we know that there's going to be that period of time where they're going to start following a gluten-free diet, that their requirement may change. I haven't personally seen the requirement go to zero, meaning that following a gluten-free diet, you'll be able to come off of the levothyroxine, but certainly reduced requirement we've seen. Calcium is something I wanted to bring up. So as Nicole mentioned, there's a lot of very important nutrients that might not get absorbed very well in patients with celiac disease. And if you're on supplementation for things like iron, like calcium, it's very important that we tell patients, and also, sorry, multivitamins even, it's very important that we tell patients to separate all of those supplements from your levothyroxine or Synthroid pill, because they will affect the absorption of the levothyroxine. So the best way to take levothyroxine is on an empty stomach, away from any type of medication, supplements, or food, especially things that contain calcium and dairy products, by at least 30 minutes, but usually I recommend 1 hour, just to ensure adequate absorption of the pill. And sometimes, that's hard for people, especially if you're like me, you wake up and drink coffee right away before you're even out of bed. And I'm telling you to do this on an empty stomach. So sometimes I tell patients to take their pill at night. So after we have dinner, most people, don't eat again for about an hour before they go to bed, and usually aren't taking supplements at nighttime. So that seems to be a better time to take the pill and separate it from everything else for some people. And then I wanted to mention biotin. So biotin is B7, vitamin B7. It's over the counter, and a lot of you may have heard of it. It's become very popular recently because it's been shown to increase the strength of hair and nails, which most people want. And a lot of people might take biotin or have biotin in their multivitamin. And uh, the way that we measure TSH in the lab on blood samples, for whatever reason, it seems to interfere with how that lab measurement is done if you're taking biotin. So it will give you a falsely low or falsely high TSH level if you're on biotin at the time of your thyroid blood work. So I always ask patients, upfront at the initial consultation, to tell me all of the supplements and vitamins that they're taking. And it's better if you bring them all to your doctor's office too. And sometimes I find patients are on biotin and they didn't know it because it's in different supplements. And then I ask patients to make sure that you stop taking any biotin containing supplements for 3 to 4 days before you do any thyroid blood work, to ensure that there's no interaction between the biotin and the thyroid blood work results. So that brings me to the end of my portion of the talk. Thank you for listening. And I just have the Thyroid Foundation of Canada website there, which has great patient information, if anyone's interested in resources for that. And I will hand it back to, I guess, Kaylee, to open up the Q&A.
Amazing. Thank you so much, Tala and Nicole. That was very informative, really interesting, especially those red flags for people with thyroid disease that you're looking into. Yeah, really interesting. I never knew that. And how celiac disease could be or should be considered when increasing the dose requirements of Synthroid. That's really interesting and a good point to keep in mind. So thank you guys for those presentations. We'll now move on to our Q&A session. We have some already in the chat here. If you didn't, or if you have a question and you didn't already put yours in the Q&A box, you can do that now. We have one from an anonymous attendee. So if your TTG IgA antibody levels for celiac disease are back to normal, is it possible you might need less thyroid medication? So I think, Tala, you mentioned this before.
Yeah, I did mention it, but yeah, in general, it's certainly possible, and I've seen that. And it really depends on your TSH levels. It's very variable. So in theory, we would assume that it's possible, but there's a lot of other factors at play. So it really, we titrate the dose of the levothyroxine to the TSH, and so often we'll have to just follow the TSH levels and go up or down depending on that.
Perfect. One from AG. With celiac disease, if it lies dormant, will you test negative and the possibility exists to test positive down the road? Nicole.
Yeah, so I've got a cat rubbing up against the screen.
Okay.
Yes. Yes. So with that gene, so what I didn't discuss was how and when celiac disease is triggered in your life. So you can develop celiac disease anytime from birth until essentially, until the end of your life as well. So we have these genes, they're triggered on at some point in your life. By various things, pregnancy, trauma. We're looking into all sorts of other reasons why celiac disease can be triggered. Oldest person ever diagnosed was 101 years old, and babies, as we know, can be diagnosed. So it doesn't lie dormant per se, but what it does is you carry the genes for it, and then something in life will trigger it, and that can happen at any stage.
Perfect. Yes, it's important to get tested every few years if you're having the symptoms as well. So another anonymous attendee, is there also a correlation between celiac disease and parathyroid disease? My daughter has celiac disease and I have parathyroid disease.
That's so interesting. So no, not in theory, in the sense that the hyperparathyroidism is a separate genetic predisposition, separate types of genes. And totally separate sort of symptoms. The main issues with hyperparathyroidism being a high calcium level, which if anything, you'd have the opposite in celiac. And then same with thyroid disease, no real overlap between thyroid and parathyroid disease from a genetic perspective. However, it really depends on the cause of the hyperparathyroidism. Parathyroid adenomas are the most common cause. And as I mentioned, they have separate sort of genetic factors. There is hyperparathyroidism, or hypo, more commonly parathyroidism, that's autoimmune. And so if that's the etiology for the parathyroid disease, then yes, there may be potential overlap with autoimmune thyroid disease. But generally speaking, although it's a very interesting overlap, not a specifically correlated one, at least not proven by research. But I mean, genetic sort of predisposition in general is such an ongoing area of research that we don't have all the answers in terms of the genes.
Okay, interesting. We have another one here. Is there a difference between thyroid disease and autoimmune thyroid disease? I think a few people asked that.
Sorry, thyroid disease and autoimmune thyroid disease?
Yes.
Okay. Yeah. So autoimmune thyroid disease, as I mentioned, the main things you're looking at is Graves' disease and Hashimoto's. There are other types of thyroid disease that are not autoimmune. Certain types of thyroiditis, which is inflammation in the thyroid, that can be from medications. That's not necessarily autoimmune. It can be from injuries to the thyroid, like at times of surgery, for example, not really autoimmune. There's a couple other types of thyroiditis. Thyroid nodules are also not really autoimmune driven, although in Hashimoto's you can get a bumpy, lumpy thyroid just from inflammation, but not actual large nodules. So as I mentioned, it's a spectrum of Graves and Hashimoto's and a few things in between. I'll say most thyroid disease is considered autoimmune, but there are some types that are not.
Okay, perfect. Let me see. Is the prescription Synthroid the only medication? Any natural things we can eat to help with hypothyroidism?
Good question. So, Synthroid is the brand name. There's other brands of levothyroxine. L-Troxin is another one that comes up sometimes. But it's synthetic thyroid hormone, essentially. In terms of natural supplements, so there's some supplements that contain iodine. There's some supplements that contain other types of thyroid biodegradable products. I'll say that from my experience, and I'm biased, I guess, because I work in an academic center, but I don't find that any of those supplements are adequate at controlling thyroid levels. I really advocate that
for normal thyroid levels and normal thyroid health, you do need the adequate supplementation that isn't seen in those types of supplements. Those types of supplements can be secondary things to your Synthroid, but I don't think that they're able to fully control the thyroid hormones on their own. When it comes to diet, so there's been a lot of research about different iodine-containing diets and adding in things, taking things out. For example, patients without celiac disease following a gluten-free diet and trying to see if that helps downregulate the immune process in the thyroid, or dairy-free diets, things like that. No convincing research has shown adequate results. So although there's some signal in the research that maybe doing gluten-free diet in patients without celiac, or dairy-free diet, or certain types of natural supplements like selenium comes up sometimes, may help down-regulate the immune response and the inflammatory response, there's no research that's been convincing enough to say that doing that will actually make a clinical difference in the thyroid hormone levels.
Okay, perfect. Another one, I think for you, Nicole, if on a strict gluten-free diet, how possible is it to still have absorption issues?
So it is possible, certainly at the very beginning. So what we would expect is that your gut will heal over time. That's the anticipated expectation, that as you go on that strict gluten-free diet, that your villi will heal, your TTG levels will come down. If you are finding that your symptoms are continuing, then that it's certainly recommended at that point to visit with a registered dietitian and talk that through. You should be on an ongoing basis having your TTG tested every 6 months until it has normalized, and then once a year thereafter for maintenance to ensure that your TTG levels are low. But the average is about 2 years, or 2 years is the average sort of adult time to have your gut heal, although some studies have shown up to 5 years are needed to heal your gut. So depending on how long you had celiac disease for, how much damage was done, and how successful you are in implementing that gluten-free diet are all factors that will contribute to the healing time.
Thank you. Lots of questions here. I think, so does the villi come back to 100% normal if we were at 250 IgA? I think you kind of discussed that there. How accurate is the blood test for celiac? My blood test did not show celiac, but I was positively diagnosed after an endoscopy.
Yeah, so that certainly happens. We've seen this before. So the TTG is an IgA dependent test. And if people have an IgA deficiency, then the TTG result is not going to be telling of anything. It's not going to be a reliable result. So I do have some patients who we call these people seronegative celiac disease patients. So they're seronegative because their TTG never triggers, but they are in fact diagnosed via the gold standard, which is actually through the intestinal biopsy. So we would always take the results of the intestinal biopsy as the gold standard results over the blood test. So regardless of whether your blood test is positive or negative, if your intestinal biopsy shows that you do have villus atrophy and you therefore are being diagnosed with celiac disease, that is what you have.
Mm-hmm. Interesting. So is there still a high correlation between thyroid disease and celiac disease, even when you eat gluten-free? I'm not sure who wants to take that one.
Tala, do you want to take that one, or I can give you my best assumption, but I don't know if it's a evidence-based answer. So I'm going to let Tala take this if you've got the evidence-based answer.
I don't know if there's any evidence. So can you repeat the question again? I just want to make sure I interpret it right.
Yeah, so is there still a high correlation between thyroid disease and celiac disease, even when you eat gluten-free? So if you're on a gluten-free diet, is there still a high correlation between the two?
Yeah, I would say there is, and the reason for that is that the genes that we're born with, the genetic predispositions that we have, although other things may upregulate that process to happen faster. Like if you do eat gluten with celiac, you know you're going to upregulate inflammation in the gut, but also diffusely in the thyroid and other autoimmune areas. And if you don't eat gluten, you downregulate the inflammation in the gut and in the thyroid. But at the end of the day, the genetics that you have to predispose you to certain conditions over time and with certain triggering factors, you know, most likely will appear. Now, if they don't appear in some people or versus other people, we don't know why that happens. But if you were predisposed to get thyroid disease, you know, even if you're not eating gluten and you're following the diet, I think if that predisposition is there, it will happen on its own accord and it will declare itself with the underlying triggering factors that we don't completely understand. But I don't know if Nicole has more to elaborate on that.
I think that sounds great.
Perfect. If the research on gluten-free diet and Hashimoto's isn't convincing, what is the benefit of this diet?
So not convincing in the context of people who don't have celiac disease. But certainly with celiac disease, I mean, Nicole went through that about the reasons why adhering to that is important.
Can a colonoscopy show if you have celiac disease?
No, so this is something that's commonly, again, a kind of an assumption that a lot of people made. I had a colonoscopy and it came back normal, so I don't have celiac disease. What we're looking at, the colon looks at the very bottom of the digestive tract, right? We're looking at the colon, where we see the most prevalence of celiac disease is actually in the upper digestive tract, in the duodenum, and somewhat in the jejunum. We've had video endoscopies that have showed presence of celiac disease and the villus atrophy in the jejunum area as well, but it's really the duodenum and the duodenal bulb that we're really wanting to biopsy, and that's done via endoscopy through the throat down into your gut, and then they take 4 to 6 samples of the duodenum at that time and then take it out, and it's fairly quick procedure. It's 15-20 minutes. Not everybody is actually even put under. Some people are just consciously sedated in order to get that done. But colonoscopy absolutely cannot diagnose celiac disease. It's a common misconception.
This one by an anonymous attendee. If gluten is eaten by mistake, does that start the healing process of the villi all over again?
Yeah, so I love this question, and I love to reassure people on this one. Everybody gets gluten. Everybody is going to get gluten. You're going to make mistakes. You're human. Don't beat yourself up because it's going to happen. My daughter, who is the daughter of a dietitian who works with Celiac Canada, has been glutened. So my mother has been gluten. My husband has been gluten. So it will happen. And I've had, mothers terrified that it's going to set you back to square one. And it's absolutely not the case. So single gluten, there's a reason why the gluten challenge, when we're testing somebody for celiac disease and we're putting them back on gluten, that we keep them on gluten for 8 to 12 weeks, because it takes that long for the villus atrophy to occur. So a single episode of what we call a glutening or accidental gluten exposure is not going to cause you villus atrophy. It's not going to cause your TTG to go up through the roof, and it's not putting you back to square one. What a single gluten exposure is misery. And it is something you have to tolerate through time, self-care, and symptom management as you can. So often what our community will do is they'll have a hot bath, sit with a hot water bottle or a heat pack, sip on some ginger ale, watch some Netflix, try to get out of the pain in your body a little bit. But really it is time and self-care and just doing what your body tells you is the right thing to do. At this point in time, there's nothing else that we can do. We don't have a medication yet to treat a gluten exposure. However, I can reassure you that you will not be going back to square one.
Perfect. We have still lots of questions left, so we'll do a few more here. So we may run a little bit over time, but we'll try to get through a few more. Is there a normal range for TSH levels in teenage girls? My daughter has celiac disease. Her blood is showing elevated TSH levels, but possibly not high enough to medicate. And we've been monitoring for over 2 years now. How long is it safe to leave elevated without medicating?
So the normal range for TSH is going to depend on where the lab draw is done. Every lab calibrates their normal range based on standard deviation of the population tested in that specific area or lab or assay that they're using. So regardless of what number I say is normal, it really depends on what the lab value for where the testing is done says it's normal. In terms of in the sort of teenage 18-year-old population, we would apply the same value for adult range for the TSH there. In terms of, is it safe to follow? Absolutely. So we have patients who have mildly elevated TSH levels with positive antibodies for many, many, many years before they develop over hypothyroidism that needs treatment. That duration of time where we're doing surveillance and following them, there's no sort of side effects or issues or increased side effects with monitoring. Of course, if there's symptoms that start to occur or increase, or the TSH level goes above a certain threshold, or the trajectory is going up over time, or the free T4 level is low, then that is overt disease and then would require treatment. The only other scenario that I would treat, even in the subclinical range, is if the patient was trying to get pregnant, because then we have much stricter levels of what the TSH should be during pregnancy. And so that would be a scenario we would treat in the subclinical phase.
Perfect. Is there any research on gut dysbiosis and thyroid disease? Gut dysbiosis is a trigger for other types of autoimmune diseases. Is it a factor in thyroid disease?
So I'm not an expert in this area specifically. I know there's a lot of research that's suggesting some relationships. Again, not anything from a research perspective that's convincing enough, that's shown a big enough difference from a clinical perspective that I would say follow this diet or change that in terms of the gut and the thyroid. Yeah, take that with a grain of salt, because I haven't looked into the research of that specifically. I don't know if maybe Nicole knows more about it, but that's my 2 cents.
I apologize. I was writing some answers to questions on the Q&As, so I wasn't listening at that point, but I doubt I would have more to add, Tala. I'm sure it was a perfect answer.
That's okay. We'll move on. Linda, question from Linda. If I have celiac disease and it is under control, how does Graves and type 2 relate? One is an autoimmune condition and the other is not, but as I understand, thyroid disease can affect blood sugars no matter the type of diabetes. I was just diagnosed with Graves and type 2 diabetes within 6 months of each other.
So, yeah, type 2 diabetes and Graves' disease, as far as I know, there isn't any specific link or overlap that I know of. And there are sort of different genetic processes. Type 2 diabetes is not autoimmune driven like type 1 is. I don't know about a specific link. Now, about the mention of thyroid diseases affecting blood sugars, not to my knowledge. So having very uncontrolled hypo or very uncontrolled hyperthyroidism will affect your blood sugars, but it's also going to affect every organ system. So yes, at very high or low levels, it will affect your blood sugars. But in the usual ranges that we diagnose people with, and especially once they're on treatment and their thyroid levels normalize, there is no significant effect on blood sugars. I think the fact that being diagnosed with type 2 diabetes and Graves within a close time of each other may have just been that once one was diagnosed, there was more blood work, investigations, and sort of finding other things incidentally. But yeah, maybe there is genetic links or overlap that I'm not aware of, but that's my knowledge so far on the topic.
Okay, interesting. So we still have lots of questions. I don't think we can get through them all. I'm so sorry, and I hope we were able to answer your questions. If not, we may be able to do a follow-up email with some of the questions answered in that. But we will wrap up. So thank you, Nicole and Tala, for sharing your expertise today. And thank you for everyone who joined us. It was a great session. A recording of the session, along with additional resources and a feedback survey, will be sent to you shortly after this session. And again, if you want to learn more, visit our website at celiac.ca, as well as Thyroid Canada's website. So have a great evening, and we look forward to seeing you at our next webinar.
Thanks for having us.
Thank you so much. Thank you.